Okay, so this is the second part of osseous tissue, which is chapter 6. So we already saw in the previous part what were the cells of the osseous tissue, what were their function, where they are located. And now we're going to see the classification of bones according to their shape. So according to their shape, bones are classified as long, like the ones that we have in the arm, the humerus, whenever they are taller than wider. And then bones can be classified as short when they have equal width and length. And we have examples like the carpal bones that we have in our wrist. Bones can be classified as irregular when they don't fit in the long or short category or the flat category. In the flat category, the bones are thin, not necessarily perfectly flat. They can have a curve like the ones that we have in the skull, but they have two layers of compact bone surrounding a middle layer of spongy bone. In compact bone, the mature cells of the bone, they are very close together, so this will be, the osteocytes are very close together. So this tissue is denser than spongy. In a spongy bone, the cells are spread apart. And this bone, it looks like a sponge. So you already saw that tissue before. And flat bones, we have them in the skull, but we have it also in the sternum. And then irregular, like the vertebrae, they're not flat, they're not short, they're not long. So they have an odd shape. And sesamoid bones, which I mentioned them before, these are bones that grows inside tendons, like the patella. The patella is the only bone that is counted toward the 208 number of bones that we have in our body. And then the other sesamoid bones, typically they are located at the base of the thumb or at the base of the great toe. And they vary in number and they are very tiny. And we don't have specific names for them. So those will be the sesamoid bones. So for the parts of a long bone, so long bones, they have endings that we call epiphyses. So we have two ends, one that is closer to the point of attachment, which will be the proximal epiphysis, and we have an ending that is away from the point of attachment. That will be the distal epiphysis. And these epiphyses basically are the endings, and they are located in between the diaphysis, the shaft of the bone, the main part of the long bone. And the region between the diaphysis and the epiphysis is very thin. That region is called metaphysis. So, in these bones, the long bones, if the person is still growing in height, the person will have a plate of cartilage. This is called the epiphyseal plate. Once the person stops growing, that plate is going to be substituted by a line, the epiphyseal line. So in X-rays, you can see this epiphyseal plate and this epiphyseal line, and sometimes, at least when it comes to those bones that has this epiphyseal plate, you can calculate more or less the approximate age of the person based on the thickness of that plate. And that can be used in forensics. Now, inside the diaphysis of long bones, you have a cavity that is called marrow. If the diaphysis is from a bone of a young person or a young animal, this diaphysis will be filled internally in the bone marrow with cells, stem cells that are going to make the red blood cells, the white blood cells. And the color of this cavity, because it's going to be filled with a lot of blood cells, is going to be red. So you call it red marrow. If this diaphysis is made from, or it is from an adult animal or an adult in humans, you will start accumulating fat tissue. Fat tissue, it looks more or less yellowish in color, so you call this yellow marrow. And then surrounding the bone externally is going to be a membrane that is called a periosteum. And this membrane has two layers, the inner periosteum and the outer periosteum. The inner periosteum is going to have a lot of cells, and those cells are going to be osteoprogenitor cells. So these are going to be the osteoblasts that are going to form the osteocytes. And also you have within this layer the osteoclast. Remember, while the osteoblast helps to form bone, the osteoclast helps to destroy bone. And then the outer layer, the outer periosteal layer, is going to be made out of collagen fibers, and is going to be made out of elastic fibers. And these collagen fibers are going to penetrate into the compact bone itself, which is going to be the middle layer of the diaphysis, and you will attach this membrane so that the membrane won't be saggy. And this attachment point is going to be called the Charpais fibers. Internally, surrounding the marrow, no matter if it's yellow or if it's red marrow, you have another membrane that is also cellular. It has cells. This is the endosteum. Endo means inside. And in this endosteum, you have, similarly as in the inner periosteum, you have cells. So you have osteoclast, you have osteoblast. Now, something that varies depending on where you have this membrane, it is the type of cells that you have in more abundance. So let's say that you make a cross-section of the bone, and many of you have seen this. So in long bones of cows, they sell you this chunk beef, and then you see the cavity. So that cavity, it is where it has like what people call tuétano, that little fatty tissue that, I mean, for some people it's tasty. So then here we have the marrow, if you make a cross section of a bone. And then you have the compact bone here. And outside of this compact bone, you have the periosteum. Peri means around, osteum means bone. And then you have an internal layer just here. This is the endosteum. Endo for inside osteum bone. Now, so this is, let's say, layer 1, layer 2, and this one will be layer 3. The marrow is supposed to be of a certain diameter, certain width. So let's say that you have like a bone that has a marrow of an inch in diameter. You're supposed to keep it that way. You shouldn't have narrower or wider than that. Now, in the endosteum, you have cells. You have osteoblasts and osteoclasts. Similarly, in your periosteum, you have osteoclast and osteoblast. Now, remember the function. Osteoblast deposit bone, osteoclast reabsorb bone. So our bones are constantly remodeling. And you're supposed to keep this marrow 1 inch of diameter. So bone, typically, it is deposited more in periosteum than endosteum to keep that diameter. So, especially when you have fracture, well, you have a bunch of cells that forms a callus in the periosteum, and of course you form something in the internal cavity, in the marrow, but you have to have a balance. So, you not only have to keep this width in the marrow, but you have to have also certain diameter or thickness in your compact bone. So let's say that in there you have half an inch. In thickness. So what will be, and this is only with an O, sorry, endosteum. Yes. Yes. So what will be the proportion of cells in the periosteum and in the endosteum, in which you will have more of one type and less than the other, according to the function. So, for instance, in the endosteum, which one would you have more active, osteoblast or osteoclast? To maintain this diameter. So, if you would have,
Well, to maintain is osteoclast,
yes,
because that's what the function is, maintaining.
yes. So if you have more osteoblasts here active, what would happen with the marrow?
It would be
You will start narrowing down. So you will have to have less osteoblast activity and more osteoclast activity. But then you don't have to weaken your bones, so you want to maintain also your compact bone layer. So instead of making it wider by having more osteoclast and osteoblast, how will be the ratio of function in here? imagine if you go to the supermarket and then in these aisles where people who shelves the items into the shelf, sometimes they bring like boxes and they go through a little bit the aisles. So then you want to have balance, okay? So similarly here, you want to have balance. So which one of these cells you will have the most to maintain the bone thickness?
When you do those,
So you will have to have
more class.
more osteoblast and less osteoclast. So sometimes when you have more activity of osteoclast and osteoblast, and the other one doesn't balance, then you will have osteoporosis, weak bones.
So you have less tétano.
Yes.
To make tacos.
Yes. And then at the endings of the bone, you have this protection, this hyaline cartilage. If you have eaten chicken legs or thigh, at the ending of those bones, sometimes you end up with a chewy part. That chewy part, that's the hyaline cartilage. That prevents bone-to-bone contact. Bone is very hard. If you have direct bone-to-bone contact in our limbs, our bones will be all damaged. And that's what happens with certain people that have diseases like osteoarthritis or rheumatoid arthritis. They damage their cartilage and they end up with deformities in their articulations, in their joints. So here is the long bone structure then. Diaphysis, the middle part, epiphysis, the endings, and it's not labeling here, but the metaphysis is here in this region. And this is, of course, the external view. This is the internal view. We have these charpes or perforating fibers that holds this membrane, the periosteum. And then in the diaphysis and also in the epiphysis, we have blood vessels that comes and gives blood supply to the bones. Cartilage doesn't have blood supply, but bones they do, and they have abundant blood supply because this is a tissue that it's very important. It has to have a lot of strength, and these cells they receive oxygen and they receive nutrients through this nutrient artery. And at the endings, externally, you have the pad of hyaline cartilage that you call articular cartilage. Now, if you make a section, a longitudinal section, a section along the length of the bone, you will be able to see that in the epiphysis, at least in the proximal epiphysis, which is this, you have red bone marrow. And in the proximal epiphysis, you have spongy bone, but you don't have the marrow there, the red marrow. Now, here is the cavity, the yellow bone marrow, and then here's the compact bone, and then outside you will have the periosteum. And this cavity, it is filled with the endosteum, and or layered internally with this endosteum. So something that you can say about this bone, because you see this yellow marrow in the cavity, that it is a bone from an adult. Adults, we still make in our bones red blood cells, but this is typically in the proximal epiphysis. Now, if someone has a problem, like anemia, our body tries to compensate. That's the homeostatic mechanism. And some bones, even it will be in adult, you will have this red marrow instead, just as a compensatory mechanism. So now the microscopic structures of compact and spongy bone. Another name for a spongy bone is called cancellous. So for compact bone, we have the functional and structural unit, which is called the osteons. The osteons are surrounded by these lamellae, which is layers of bone, compact bone, concentric layers. So that's the concentric lamellae. The osteons, they have a central cavity that is called the Haversian canal. And through this Haversian canal, blood vessels goes through. And then to the sides, these Haversian canals have these canaliculi, like little channels. Canal itself means channel. And then in between the concentric lamellae, you have the little spaces or lacunae that holds the osteocytes. And the osteocytes extends part of the cytoplasm in these canaliculi, and they contact each other. And through this contact, they can share nutrients, they can share signals. Now for the cancellous or spongy bone. Well, the lamellae looks like struts that go randomly. They form trabeculae, what is called trabeculae. And we also have lacunae. Remember, lacunae means lake. Laguna in Spanish is lake. And then this bone doesn't have osteons. So we don't have the central canal there. We don't have the concentric lamellae. We don't have canaliculi. And both of them, no matter if it's spongy or compact, provide a structure and support, and a strength to the bones. So here is the histology of compact bone. This is a cross-section of the shaft. So this is the endosteum. This is the periosteum. This is the compact bone. And then at least in this part of the cavity, you have spongy bone near to the endosteum. So each of these represents an osteon that was telescoped out. And then in the middle of these osteons, you have these blood vessels, and also you have a nerve. This is called the Haversian canal or central canal. So you have an artery, as seen this in red color, a vein in blue color, and a nerve in yellow color. If you telescope one of these osteons more, you will see 3 layers. These are 3 concentric lamellae. Not that each of them has 3 concentric lamellae. They can have several, but it's just to illustrate. So these concentric lamellae are layers, circular layers of bone, calcified bone, and they have as well the collagen fibers. And see how it's shown with angles at different directions? Well, what it's pointing is like the collagen fibers, they follow that direction. So these ones, it's in this angle, the other one's in the opposite angle. And that gives basically the way to transfer the physical forces in different directions to help the bone to be resilient to stress. So these layers of concentric bone or concentric lamellae, they have studded within the osteocytes. So this is an osteocyte, this is another osteocyte, and then these osteocytes, they look like a star shape, and they extend their cytoplasm through this canaliculi. So this is a transverse section of the bone. So it's like if someone makes a transverse section and it shows you this. So this is the central canal. This will be the concentric lamellae. And then in this part, so this is the central canal, this is the concentric lamellae, this is where you have the lacunae with the chondrocytes. And these are the canaliculi. And then you have coming out from the diaphysis or from the external part of the bone, the periosteum, this nutrient artery goes from superficial layers of the bone to deeper layers. So this is more external, this is more internal. So as this nutrient artery goes, part of these arteries can go in between this central canal, but as it's going deeper, it runs in these perforating canals. And same for the veins. And this is the periosteum, a little bit detached. So we have the Charpais fibers, which are collagen fibers that attaches this periosteum into the bone. Any questions about the compact bone histology? Now for the spongy bone histology. So we take a sample from one of these endings, the metaphysis, and then you magnify it. So here you have this bone, not as a concentric lamellae, but as trabeculae. So these are rods of bone. And then internally, in this membrane, we have the endosteum. And then in this endosteum, we have this osteoblast. And yes, we have some osteoclasts. Remember the difference? Osteoclasts are gigantic cells because they merge. 4 to 5 osteoclasts, they merge, or macrophages, these are macrophages, they merge, and that's why they end up with a lot of nuclei. And these are the ruffled borders. And these ones are smaller, but these ones deposit the bone while these one reabsorbs the bone. And these trabeculae, if you make like a section and you see it, well, you have these cells found in the lacunae, the osteocytes, with the extensions of the cytoplasm in the canaliculi. So they contact each other, they share the nutrients, they have gap junctions, like little windows through which they can share calcium, magnesium, any ions. And then they send signals among each other. But spongy bone is specialized to make blood cells, while compact bone is for protection and to provide a structure. And this is how actually this spongy bone looks like. So this is the trabeculae, this is the endosteum, osteoblast, and osteoclast. Look how this osteoclast is very giant in comparison to these tiny ones. Multiple nuclei, this one only one. And then you have your osteoblast and your osteocytes. For the histology of flat bones, so it's a sandwich. You have 2 layers of compact bone that are thin, and then they surround this middle layer, the sandwich part, of spongy bone. Spongy bone in this type of bones, the flat bones, it's called the diploid. And it's even written with these little dots on top. Any questions? Okay, now let's look at the three types of cartilage and where they are located. So cartilage, just as bone, it is connective tissue. It's one type of connective tissue. And then in this cartilage, we have cells, which are the chondrocytes. And then we have the extracellular matrix, which is made out of proteins. And then also glucose molecules. Now, one difference between cartilage and bone tissue is that cartilage is avascular. It doesn't have its own blood supply. But then where does the cartilage get its oxygen and nutrients? Well, it's by diffusion, because cartilage has nearby highly vascular tissue, which is the bone, and the bones, they share the nutrients. They diffuse oxygen, nutrients, whatever the cartilage needs. We have three types of cartilage: hyaline, fibrocartilage, and elastic cartilage. You already seen this in the previous chapter, but this is a little bit more detailed. So hyaline cartilage, we have it in different places in our body. The consistency, it is intermediate. It's not as elastic or as soft as elastic cartilage, and it is not as hard as fibrocartilage. Places in the body where we have it: in the respiratory tract, like bronchi, trachea, growth plate of lung bones, when someone is growing. I mean, before we born, most of our skeleton is made out of hyaline cartilage. Very few bones are not made out of hyaline cartilage. So then once we start ossify these bones, we leave in the long bones part of it as we still grow, but then when we stop growing, that cartilage become ossified, so we end up with a line. And then we have it in the ribs, like the connecting part of the ribs, the tissue, bone tissue itself to the sternum is made out of hyaline cartilage. The tip of the nose, if you want to know what is the consistency, just press a little bit the tip of the nose with your index. It's not as hard as fibrocartilage, but it's not as soft as elastic. Elastic, we have it in our earlobes, or well, in our ears. Not in our earlobes, but in the ears. So that's why they flap back after you bend them anteriorly. So another place where we have elastic cartilage is in the epiglottis. The epiglottis is a cartilage that closes the larynx, the voice box. When we are going to drink or eat something, the larynx, the voice box, is supposed to be closed. So this epiglottis falls over the larynx, and then the food goes posteriorly into the esophagus, the tube that is going to bring the food from the oral cavity into the stomach. And then when we are breathing or speaking, that epiglottis opens so that the air comes in and out. Fibrocartilage, the hardest type of cartilage that we have. I mean, the name itself tells you something. Fibros means strong. So fibrocartilage is located in between the vertebrae, in the intervertebral discs. And also we have it in the knee joints and between the pubic bones. So places where we need protection, that's where we have this fibrocartilage. Questions about the types of cartilage? Okay, so now let's talk about osteogenesis. How does bone formation occurs? So, our bones can be formed two ways: by one, intramembranous ossification, or by endochondral ossification. ossification itself is forming bone. So you can form bone inside a membrane. That's why it's called intramembranous ossification. And in this case, we have very few places in our skeleton that this type of ossification happened. Like, for instance, most of our skull bones and the clavicles were formed inside a membrane. This happened, of course, during fetal life. We have these mesenchymal cells that they form this type of bone. And then in endochondral ossification, which is the rest of the bones of our body, we had a model of cartilage, hyaline cartilage, that after we have calcification, this cartilage became a bone. So here is the process of intramembranous ossification. So again, we're talking about most of the bones of the skull. Like if you make a magnification of the frontal bone. So we had these mesenchymal cells in this area of our body, in the frontal bone, and they became a primary ossification center when they receive signals from the DNA to tell, okay, mesenchymal cell, you're going to become an osteogenic cell. And this osteogenic cell is going to differentiate, is going to become an osteoblast. So this is coded in the DNA for these mesenchymal cells to become osteogenic cells and then osteoblasts. Now, this happens in an area that is called the primary ossification center. And then the next step is for these osteoblasts to deposit collagen fibers, what is called the osteoid. So this then start depositing this osteoid, and then they become trapped. When they become trapped, they are forced to become an osteocyte. So it's a differentiation process. Starts in mesenchymal cell, go to osteogenic cell, and then go into osteoblast stage, and then go into osteocyte. So a baby becomes a child become an adolescent become an adult. So these are the steps of differentiation that happens then. And then with factors that are found within the cells, they secrete molecules that will attract blood vessels. And these blood vessels will bring calcium ions, will bring nutrients, and then you will develop this trabeculae. This is early spongy bone. And then some of the surrounding cells of the mesenchyme will differentiate and they develop periosteum. And in this area where you have your blood vessels, you will have more osteoblasts secreting organic matrix so that you grow this bone and then you form compact bone. So those are the ossification steps in intramembranous ossification. Now for endochondral ossification, again, you have a model of hyaline cartilage, which is this. And then in this model, you have this central part that is going to be the future diaphysis, and these endings that are going to become the epiphysis. So, something that happens within this middle part, the diaphysis of the future bone, is that you will release as well by these cells that you have internally, you will release morphogenic factors. So these factors are going to attract blood vessels into the middle to form the primary ossification center. And these cells that you have here, which are the osteogenic cells, will become the osteoblasts. And these osteoblasts, they will start depositing osteoid or collagen fibers. This substance is going to surround these cells, the osteoblasts, and they will mature into osteocytes. And then you will have more blood vessels coming in, bringing calcium ions, and then magnesium ions, so you will form hydroxyapatite, and then you will have nutrients, and then you will start increasing the width of these ossification centers, and at the same time, you will also form secondary ossification centers here in these epiphyses. But the first part that you start ossifying will be this central part of the bone, the diaphysis, by bringing in these blood vessels. So this is where you have your primary ossification center. Later on, in these epiphyses, you will form the secondary ossification centers. Same process, you will have your osteoprogenitor cells becoming osteoblasts that will deposit this osteoid. They will get trapped in them, and then they will form these osteocytes. And the last part that you ossify is this plate. So you leave a little bit of this plate. And then when you stop growing, this plate will become a line. And at least in this area, something that is going to happen is that you will have increased number of mitosis in certain areas to increase the bone in length as well. So how does the bone grows and repair? Well, you can have bone growth in length, which is called longitudinal growth, that happens in the epiphyseal plate by division of the chondrocytes. So the chondrocytes undergo mitosis, and then when you have certain factors that allows it, you have this mitosis, but then you run out of these factors, then this stops, and then you start ossifying your cartilage. And then you can have depositing of bone around. This is called appositional growth. So that will increase the bone in width. Typically, when we are young, of course, we increase the bone in length to according to many factors, including genetics. But then when you stop growing, your bones can increase the width. No matter how thin the person it is, even in later stages in life of the person can see pictures when the person was younger, and it looks a little bit different. The person can be thin later on in life, but it looks thinner when he's younger, typically, because of the bones. They're not as thick as when you are young. They're a little bit thinner. Now, what hormones helps to or participate in the growth of bones? Well, would be growth hormone, which is secreted by a gland that we have in the brain that is called pituitary gland. We have also testosterone, estrogens that helps in the growth of bones, maintains the density of the bones. Females after the age of menopause, they start losing density in their bones because estrogens are gone. Estrogens not only help to maintain the density of bone, but many other tissues in the body. So the bones become weaker after menopause. And then for fracture repairs. So first you form blood clots. So you have basically a little hemorrhage within the bone, hopefully it's little. So you control it, that's called hematoma. And then you start depositing cartilage. This is soft callus. And then you start ossifying this cartilage, this hyaline cartilage, you form a hard callus, and then you have remodeling. Fibroblast, the cells that deposit these collagen fibers participate as well, guys, in the repair of fractures. So here is the steps of fracture repair. So you have here break of these diaphyses. So these blood vessels, of course, they will become damaged. They release blood, and this is hematoma. This blood will remain here. It's important to have blood because where do we have the calcium ions? Where do we have the amino acids to form collagen? Where do we have the growth hormone? We have it in the blood. So then your blood vessels helps to bring these materials to repair the bone. So you start then forming out of these osteochondral progenitor cells, you start forming these osteoblasts. The osteoblasts, they will basically, or the chondroblasts, sorry, the chondroblasts, they will form cartilage, this soft callus. And then you have the fibroblasts that are going to start depositing collagen fibers. So you have organic matrix, and later on, this organic matrix is going to be calcified in the third step, which is hard callus. So you will replace this chondroblast for osteoblast. And the osteoblast, they will mature, they will form these osteocytes, which is going to be the last maturation step of the cells. And you will have bridging of these two pieces of bone by new bone, and then you have to remodel. So you have osteoclast removing the excess of tissue. Our cells, our body, it is not stingy. Why will it put more bone than what is necessary? Well, you don't want to run the risk of someone being not careful enough, not taking care of its already repaired bone, and maybe add more pressure when it's not needed, and then break the bone again. So it adds more than what is needed, but then later on, you have your osteoclast coming and removing the excess. You have a repair person going into your home when it's covering a hole in the wall, in the sheetrock. You will see the plaster that they put. Initially, the plaster is not perfectly flat. There will be excess of plaster then they will start sanding, and then hopefully they will clean up. Yes.
In newborn babies, most of them have like a soft spot on the clamp. What's the main purpose of that? Is it brain growth or?
I'm so glad that you asked that because I forgot to mention that. Yay. So I was asked what is the purpose of having these soft spots. And actually, the soft spots guys, is the intramembranous, or well, it's the membrane, right, that is going to become ossified. So a baby less than 2 years old or 18 months, you will feel in certain areas of the skull these soft spots. That's the membrane that is going to become ossified. So during the first 2 years of life, our brain expands, it grows in size. So you need to have that soft spot to accommodate for the growth of the brain. Not only that, but if the baby born through the birth canal is narrow. So they have to have a way to accommodate for that. Okay, so that's why we have those soft spots. And I think we're going to talk about them a little bit more in the next chapter when we talk about the skull bones. So for bone growth in length at the epiphyseal plate. So in the epiphyseal plate, we have 4 zones. From the zone that it is closer to the epiphysis to the zone that we have closer to the diaphysis, that's how you will have the proliferation of chondrocytes, maturation of chondrocytes, and calcification of these chondrocytes. So you have regions 1 through 4. So the most external is going to be region 1, the most internal is going to be region 4. So in region 1, we have the zone of proliferation. So you have constantly dividing these chondrocytes. They undergo mitosis, so you form more. And then, of course, these will be surrounded by the extracellular matrix. The next zone is going to be called the zone of hypertrophy and maturation. So these newly made chondrocytes are going to move into this next zone, and then that's where they start becoming bigger. This is hypertrophy. And then they will start maturing as they move to the next zone, which is the zone of calcification. So in here, these chondrocytes will die, and then you will have deposit of calcium salts, and in the next layer, the zone of calcification, this cartilage will be completely surrounded by calcium salts, calcified cartilage, and the last part is going to be the newly formed bone. So proliferation, maturation, calcification, and newly made bone. That's the way our bones grow in length. And this is the actual view of these phases or these zones in the in the zone of growth. So proliferation here, hypertrophy and maturation, calcification, and ossification. So calcification is just simply depositing calcium, and ossification is transforming this tissue into bone. So one of the reasons why we have this remodeling of bone is to help to maintain calcium homeostasis. Yes, there are, and I envy those people who are very disciplined. They make sure that in their diet they have everything that they need. But most of us, we don't take our daily pills of calcium. and then our diet is so deficient in calcium that ultimately we need calcium from a storage form of calcium. The most available storage form of calcium that we have will be the bones. We still have calcium, of course, in our teeth, guys, but that one hopefully never goes away. So then this bone remodeling, it is given by the balance of osteoblast and osteoclast activity. Okay, yeah, we went over that, and then we say, well, in order to maintain this diameter of the marrow and this thickness of the compact bone, we have to have this activity or this number of cells into this ratio. But let's say that someone doesn't ingest as much calcium during a particular day. Well, in this case, you don't want your osteoclast being activated so much in your bone marrow than in your periosteum, but you still have your osteoclast reabsorbing bone because you didn't ingest enough calcium. In this case, you will have thinner bones. But let's say the next day, you ingest enough calcium and more than so, and then you start depositing your calcium salt by your osteoblast. And then you have this hormone, parathyroid hormone, that is released by 4 tiny glands that we have behind the thyroid gland that we have here, that helps to increase calcium levels when your calcium levels are low. So they activate your osteoclast and they inactivate your osteoblast. But then we have the antagonistic hormone, which is calcitonin. It has the opposite effect as parathyroid. This one deposits bone, and this one is produced by the large gland that we have in our neck, which is the thyroid gland. So if you ingest in your diet enough levels of calcium for the day, plus you take your pills, well, your bones are going to be so happy. Your calcitonin is going to be released and you deposit that calcium in your bones. Of course, you don't want to have excess that you end up with ectopic calcifications. So you have to have also a balance. And then we have vitamin D that typically is produced by our skin when you expose your skin to the sunlight. But if not, if someone, for instance, lives in an area of the world where there's not so much natural sunlight, in this case, the person has to take supplements of vitamin D. But vitamin D helps for absorption of calcium by intestinal cells, so that calcium will be available. So it's not only ingesting calcium, but also what helps you bring this calcium into your bloodstream. So then, here are the players of calcium homeostasis. So let's say that you have hypocalcemia, that's the name for having low calcium levels. So your calcium levels drop, then your parathyroid glands, so these are these little 4 dots that are behind the thyroid gland. So this is the shape of the thyroid gland. It looks like a butterfly with open wings. And then behind this thyroid gland, these tiny parathyroid glands, they release PTH, parathyroid hormone. And this PTH will make your bones to release calcium. So this is your bone, your osteoclast starts chewing up the bone, then calcium goes into your bloodstream, and then hopefully you have vitamin D available by your, either you take it by your supplements or you expose yourself to the sunlight. So something that happens with vitamin D is that skin initiates the process, and then the kidneys and the liver completes the process of maturation of this vitamin D, but then the kidneys and the intestines also absorb calcium. Calcium goes up in your bloodstream, and then you regulate it to normal levels. Calcium is so necessary. Your heart always beats for as long as you live, 24/7. It always needs calcium. Calcium is necessary for muscular contraction. Your skeletal muscle as well, your smooth muscle as well. Several processes in our body, guys, requires calcium. Preventing of bleeding, excessive bleeding, we need calcium. Tasting, seeing, smelling needs calcium. Calcium is everywhere, it's needed everywhere. So we need to have normal levels of calcium. So for clinical application, bone disorders and fractures, osteoporosis, decreased bone density. When you have less dense bone tissue, you have increased fracture risk. As we age, we have greater risk of this. We have sometimes poor diet, including with several risk factors that lead to hypocalcemia. So we have osteoporosis, and then as we age, we have less reflexes. So we fall, and typically when you're younger, you extend your limbs or your upper limbs to prevent falling directly. But as you age, you just fall plainly, and then you break bones.
Doesn't vary in children too?
Osteoporosis in children?
No, when women produce children or bear children, the more children you have, the higher risk you have. Because a lot of the absorption comes from the bone, right, for the unborn child.
Yes, so a female who has several pregnancies, she has the risk of hypocalcemia. Why? Because you give calcium for the formation of bones for your child. But she may have several children. However, if she take adequate amounts of calcium, then the risk is not so much. Then fracture types is considered for treatment and healing process. So you have to know what type of fracture you have, and then know what is going to be the procedure for healing that bone. And then you have to have not only calcium and vitamin D, but even vitamin C is necessary for healthy bones. And let me tell you why. Well, vitamin C is necessary for hydroxylation of collagen fibers. So vitamin C then is necessary for the healthy organic matrix of bone. And then you have to have dairy products or things like that that has calcium. So here is a classification of fractures. So if the fracture goes around the bone in a spiral, this will be called a spiral fracture. It can be seen typically as an angle, but it covers the entire perimeter of the diaphysis in this case. So this is the femur. So you can see it here in X-rays. Now, if you have more than 2 pieces of bone, like in here you have 2 pieces, but in here you have 1, 2, 3, actually 4. This is called comminuted. So how do you call when you only have two? Non-comminuted. So this is comminuted fracture. And then if it's partially in the diaphysis, it's just like a little line, but it doesn't go all the way through. This is called green stick. This happens frequently in children because they have a lot of collagen fibers in comparison with a so calcified matrix of an adult. And typically children, they have higher rates of mitosis than adult tissues, so they heal much faster the fractures than adults. And now, if the fracture occur in a bone and it's not completely traumatic fracture, but if it happens in a bone that carry weight, like in the case of the body of the vertebrae, this will be called compression fracture. Now, if part of the piece of the bone separates completely, it's going to be called avulsion. When you have a physical force that makes this fracture to happen. And sometimes you can have avulsion, but in this case of the epiphyseal plate. So this is an epiphyseal plate fracture. So for osteoporosis prevention, so adults age 19 and 50, they're supposed to take 1,000 milligrams of calcium per day. Women over the age of 50 and men over the age of 70, 1,200 milligrams per day. Calcium-rich foods includes dairy, leafy greens, fortified foods. All they supposed to be preferred for taking your daily intake of calcium. Here I left a link for finding more information about all this. Vitamin D intake, 70 years, up to 70 years is 600 international units of vitamin D, and adult 70 years and over 800 international units. And then function is of vitamin D to absorb calcium, helping to absorb calcium, and you can expose yourself to sunlight as well. Physical activity is important to maintaining strong bones because that puts certain stress in the bones, helping to deposit calcium and also collagen fibers. So, especially if it's weight bearing and muscle strengthening exercises. Lifestyle factors: avoid smoking, intake of excess of alcohol consumption, because that can damage the cells that helps to absorb calcium, and also caffeinated drinks, excess of caffeine. And it's okay, coffee, but sometimes if it makes you so shaky, then that's tells you that it's an excess. And then maintain healthy body weight as well. Screening and prevention for women over the age of 65 and older, men of the age of 70. Bone density, it's important to measure if risk factors exist. And then, of course, discuss about other medications that you might taking or supplements if at risk. So look at the difference. So this is bone tissue from the vertebrae, a spongy bone. This is a huge magnification with a scanning electron micrograph, healthy bone versus osteoporotic bone. Which one is a greater risk of fracture? Of course, this one, with minimal injury. Now, in the next chapter, we're going to start seeing the classification of bones based on where they are located. We're going to see the names of the bones, the parts, and we're going to see how bones form joints or articulations. And as well, we're going to see functions as well of the skeletal system. Test your knowledge. Which bone cell breaks down bone matrix? C, osteoclast. What type of ossification forms most bones below the head? Endochondral. True or false? Compact bone is made of osseous. The structure and functional unit of bone is osseous. True. The epiphyseal plate is responsible for bone lengthening. True. Osteoblasts maintain existing bone tissue. True. What type of bone growth happens in the periosteum? A positional or longitudinal? A positional, so your bones increase in width, not in length. Okay, so that's all for this chapter.